Assalamu alaikum. Jazakallah to talk on the forum. My discussion is going to revolve primarily around the advances in spine surgery. And I'm briefly going to talk about the latest trend in the spine surgery, which is basically an endoscopic surgery. When we talk of the innovation in spine surgery, it revolves around few of the themes. Basically, your aim is to preserve the motion segments, should be minimally invasive, and if it is image guided, then it's more precise. And your ultimate aim is that you want to restore the spinal alignment. By restoring the spinal alignment, you actually have a better outcome in the long term. So that if cervical surgery is done, you need to restore the cervical lordosis, and similarly applies into the lumbar spine. You must restore the lumbar lordosis. Otherwise, you will end up with a flat back syndrome. When we go into the evolution of minimal invasive surgery, traditionally surgery, big incision, extensive soft tissue disruption, massive blood loss, scarring, and you end up cutting quite a bit of lamina, facet joints, and you cause a significant amount of morbidity. Over the years, the trend was always to move towards the smaller incisions, more percutaneous, tubular techniques, and then microscopic techniques, and eventually leading to the endoscopic technique. Endoscopic technique is the most advanced form of the spinal surgery, and the least invasive and highly innovative. Small history regarding the spine surgery. Open spine surgery from 1933, which I mentioned in the beginning, where you can see in the diagram that there's an extensive spinal exposure, muscle dissection, stripping of the muscles, cutting of the laminas, and then exposing the dura mater, and then you're going down to the disc area and removing the disc. And eventually, in 1970s, we ended up moving towards a discectomy, which is a microdiscectomy, which is still in practice. These are a few of the advantages of the minimal invasive surgery. With smaller incisions, we use the muscle to make a track. Along the track, we use different size dilators, so there's less blood loss and there's shorter hospital stay, and it's a quicker recovery. As compared to an open surgery, which is far more extensive, diagrammatically you can see this is quite an extensive incision. There's retraction of the muscle tissue, and there's blood loss and prolonged recovery. This is just on the model to show how actually the dissection and the removal of the tissue of the posterior elements and the tissue at the back, when we're doing the open surgery, you have to actually compromise significant amount of the posterior elements. Like this is, you have to cut the lamina, you have to significantly compromise the facet joints on the side. Ultimately, you expose the dura, and then you have to retract the dura down and go towards the disc area and remove the disc and decompress the nerve. That is the traditional conventional surgery which is in practice still today. That's just the axial cut of the same surgery, which we can see how extensive and wide exposure is. Now, once you have done that amount of extensive exploration around the spine, then you actually ended up having an instability. So to overcome that instability, you ended up going for a fusion, where you insert the pedicle screws and the bone grafting, and all this thing adds to the morbidity to the patient in the long term. So the goals of surgery, the spine surgery, is basically primarily to decompress the nerve. You want to maintain the stability and restore the spinal balance, alleviate the symptoms, restore the function, and if it is minimal invasive, the outcome will be far better. When we talk of the options in disc surgery, open discectomy, that's a traditional, conventional way, still practiced in many centers by many surgeons. Then you have a concept of discectomy with the spinal fusion. In those cases where we do the open discectomy and you end up compromising the facet joints, you have to end up going for a spinal fusion, which is quite a extensive procedure because you have to harvest the bone graft and you have to really significant amount of morbidity you're going to add onto the patient. Down the line, after a few years, the patient who had segmental fusion is going to come with adjacent segment disease, and then in that way, the perpetual cycle of undergoing repeated surgery carries on. Microdiscectomy, if you end up causing a compromise on the facet joints, you are asking for a fusion again. The minimal invasive spinal surgery, that's the way, and the endoscopic spine surgery, I will, during the course of the talk, I'm going to show a video where we will highlight how smaller incision and how little tissue damage we are going to do in the endoscopic surgery. When we go in the evolution of endoscopic spine surgery, the first phase was a uniportal phase of the endoscopic surgery, which was launched primarily around the lumbar spine surgery, where you use a uniportal, a single portal, which is less than a centimeter incision, and you, through the same portal, you use it as a working channel as well. The second generation of the scope, which is basically used around the lumbosacral region, which is more like an interlaminar approach, and the third generation, which is a biportal scope, where you end up giving two incisions. One is a working channel, and the other is for the scope. And the last approach is basically you can do the fusion through the scope, the spinal fusion, anterior spinal fusion, interbody fusions. You can insert different sizes cages and extra. Endoscopic spine surgery is more accepted, especially in Asia. Korea is the hub. Uniportal and biportal techniques, especially biportal technique, that is basically done mostly in Korean Peninsula, especially South Korea. Indication for the endoscopic spine surgery. You have different disc when it prolapses, it's sitting in different areas. The foraminal disc is the ideal indication, extraforaminal disc, and then obviously recurrent disc herniation. If somebody has gone for a surgery and he comes back with a recurrent pain going down to the leg, he will be a good candidate for instead of going for an open surgery, you would rather go for an endoscopic surgery. And then you have spinal stenosis and the revision surgery where there's an adjacent segment disease and you have an adjacent segment disc prolapse. If we extend the indication, the lumbar spinal stenosis and lumbar disc revision surgery, cervical spine surgery, and to a certain extent thoracic disc herniation, those are the indications which are extended into the fold of endoscopic surgery. Transforaminal, that is the key approach to the endoscopic spine surgery. Few of the prerequisites while proceeding to the transforaminal surgery, you need to know your MR scan. You need to know the detail of the disc, exactly the location of the disc where it is sitting so that your approach can be precise to the spot. Because it's more like a precision surgery. If you're not going to reach to the spot precisely, you're going to miss the area and then you're going to be lost in the track into the spinal area. The placement of the needle plays a significant role. That is what going to lead, obviously, to the site of pathology. And you must have a right indication. Otherwise, the outcome is not going to be that great. Just for the interest's sake, I'm showing 1-2 scans just to see how the disc can be prolapsed out. This is massive disc at L4-5, which is prolapsed out. And if we look at the sagittal view, it's actually obliterating the whole spinal canal. Sorry. That's the disc you can see. This is the anterior part. This is a normal disc. The spinal canal is completely obliterated with the disc. The same patient going into the axial picture, you can see the left side, the whole part of the left side canal, spinal canal is obliterated, so significant amount of the pain going down to the left side. Another patient with a similar kind of picture. This is a model view where I'm going to elaborate the area which we exploit for the endoscopic surgery. If we yeah, so it's basically a safe zone which is used just below the intervertebral nerve root, which is a triangular zone. That's the spot which is exploited for the endoscopic surgery. The needle need to be placed around there, and eventually the scope has to reach there, and that's from where you can actually go and do the discectomy. In order to go, since this is a transforaminal approach, you need to know the anatomy of the foramina through which you are approaching to the disc. The foramina, the intervertebral foramina, if you look at it, is basically oval shape. Upper 40% to 50% is occupied by the nerve. The lower part of the foramina, that's the area which is close to the disc, and most of the time the disc actually, when it is extruded, it's extruded into this zone here. So our approach in the transforaminal is primarily we are exploiting this area here to reach to this area through the scope and remove the disc without opening the posterior part of the spine. These are the different surgical approaches which diagrammatically shown on the axial cut. You have a posterior, which is an interlaminar approach where you can insert the scope primarily for lumbosacral region. And then you have a posterolateral approach, which is for the transforaminal approach. Far lateral approach is used in certain kind of disc herniation, which is more central discs. It has its own drawbacks and it has its own limitations. Endoscopic surgery is fairly new in orthopedic spine surgery. In orthopedic surgery, we have used arthroscope for over 4 or 5 decades, and therapeutically, almost 80% of the surgery done today around the shoulders and the knees or elective surgery is done arthroscopically. However, the trend towards the endoscopic spine surgery is happening in certain centers over the world. Just the instrumentation part of the scope, a normal scope, the endoscope, it has a working channel, it has its own optics, a high definition lens, and the irrigation canal, and then there's a light source. These are different these are different tubes which we use to navigate when we are going towards the spinal, towards the foramina. These are the different cut tubes which we use it while we are inserting the scope. This is a bipolar diatomy, so-called bipolar. Is like a coagulator which we use intraoperatively around the epidural area to coagulate any of the bleedings. And part of the tip is actually a longer tip. It allows us even to dissect around the spinal cord area. This is the burr which we use also in case of the endoscopic surgery. In those cases where the foramina are obliterated significantly with the osteophytes and you end up going for a like foraminoplasty or something, then we have to use these different sizes burrs. The 4 millimeter burr is with different angles. You can use it around the pathology site. This again is the area where diagrammatically where it's showing, that's the area where you're going to be going the endoscopic route. Treatment of the needle is the most critical part of the endoscopic surgery. Different approaches, the Camben triangle, that's the primary approach, and then you have intraforaminal and extraforaminal. Just from the model briefly to highlight the safe zone. This is the safe zone. The intervertebral nerve is coming out through the foramina, the safe zone, the triangular zone, and that's where the needle is supposed to be placed. And through that needle, we railroad on top of the needle certain different size tubes. I will highlight it just in the next few talks. The axial cut, the trajectory of the needle, which safe zones it runs. It runs through the posterior muscles, the rectus spinae muscles and the quadratus lumborum, and eventually you reach to the disc level. This is the disc which is prolapsed out, as you can notice on the right side, and the needle is reaching right to the spot of the disc. And that's the tube, the working channel, which has reached to the disc prolapse area. These are different angles. It's more technical, depending on your site of the disc, which angle, how much distance from the midline one is going to use. Okay, this is a 58-year-old lady, which is a cardiac patient, which is hypertensive, diabetic, grossly overweight. She presented with a right lower limb pain. The axial cut at the level of L5S1, it shows that there's a disc which is actually going across from the right to the left. It's causing significant amount of stenosis. This is like a patient which I'm going to highlight it, how the procedure exactly is performed so that one can conceptualize, because it's difficult to comprehend. How does the scope goes into the spine and you do the surgery? This is the patient. Patient is positioned in the lateral. I prefer in the lateral position because of certain reasons. The approach is much easier and you are precisely onto the spine area, plus it gives an added advantage that your abdominal viscera and all that is not really compressing into the spinal area. Before we start the procedure, the C-arm is pushed in, and through the C-arm we make certain marking under image just on the outer part of the body, and then we follow the procedure. These are the lines which are drawn, which I was talking about it. This is the transverse line along the spinous processes, vertical line at the L5S1, and that's the trajectory of the needle which is going to go into L5S1. This is intraoperatively. I'm just trying to place an instrument at the target spot. The needle has to come here for my scope to precisely reach to the spot. The nerve which is coming out from L5S1 is exiting in the upper half of the vertebra, and that's tracking down this way. So this is the safe zone which I was talking about previously in the Camben triangle. So that's where the needle is placed now. As you can see, the needle is exactly at the spot where we wanted it, in the lower third. Its trajectory is at the right angle, and once the needle is in place, then I'm going to play the video. That's the size of the incision which is going to be there. Once the needle is in place, then we railroad on top of the needle we insert the guide wire. On top of the guide wire, we railroad different size tubes. These tubes eventually gives way that we can insert our working channel. That's the working channel tube, the last tube. The aim of doing all that is basically so that you're going through the muscle tissue, you're causing least amount of tissue trauma, and you are right at the spot. That's the endoscopic picture of the area where I am at the moment. The disc is in front of me. This is a bipolar scope. This is like a bipolar diatomy coagulator which I'm using just to make sure that there's no epidural vessels around the area. Once the adequate amount of hemostasis is performed, there's a flow of the fluid which is taking place at a certain pressure just to keep the capillary pressure, the capillary under control, so the bleeding is under control. We start removing the disc, and these are about 3.8 to 4 millimeter pituitaries graspers which we use to remove the disc. Can we move it? Oh, sorry. So as you can see, the size of the incision is less than a centimeter. This is endoscopic pictures which were taken during the procedure. You can see the disc, which is visible around here. It's compressing around the nerve root area. After removing the disc, you can actually see the nerve root, which is quite free. This is the dural sac. This is the exiting nerve root, which is coming out. The disc is removed. That's the disc which was compressing on the exiting nerve root. You see. Advantages, they are quite obvious. It's a small cut. There's minimal tissue trauma. There's no muscle dissection involved here. No laminectomy, no laminotomy. There is no facetal joint compromise and minimal blood loss. No need to stay in the ICUs, high care, early mobilization, and at time, the young patients, we tend to discharge them the same day. Coming in the morning and the evening, they can go post-surgery. As compared to the traditional open surgery, which is for simple procedure of discectomy, where they end up having big incisions, extensive incisions, minimum about 5 to 6 centimeter incision, that's in the open surgery. And the tissue trauma is massive, which end up causing quite a bit of bleed. At times, you have to transfuse those patients. They end up going into the high care, to the ICU. It adds on to the morbidity in the short term and the long term. Considering regarding the anesthesia, the procedure can be done under local anesthetic. We have performed certain procedures. Certain of the patients which opted to stay awake, we use a local anesthesia. Obviously, certain degree of sedation using domicum and fentanyl extra, 1% lignocaine with 18-gauge needle, and that is sufficient. And
Once we're inside the disc, it's not really, it's quite, the patient does not really feel pain. The advantage of staying awake is that you don't have to have a neuromonitoring extra. We can ask the patient while we're doing the discectomy, move your foot, dorsiflexion, plantar flexion extra, one can see it clearly. Whereas in the other cases, if the patient opted to go for lighter anesthesia, you have to avoid using the muscle relaxants, and you have to be monitored. Neuromonitoring during the surgery is also needed. So spine surgery, durable innovation in the spine surgery, the aim is basically to preserve the motions. where it is minimally invasive and it's image guided and you need to restore the spinal alignment. That's the ultimate target of the spine surgery. I think, thank you.